Hematology. Here we have the blood cell. These cells are developed in the bone marrow and differentiated as they mature into different functioning cells. Here you can see the blood cell, stem cell, which then differentiates into different types of stem cells here, lymphoid and myeloid. This myeloid will turn into your red blood cell here, platelets, and a type of white blood cells called granulocytes. The lymphoid stem cell will turn into lymphoblast, and these are most of the white blood cells here, B lymphocyte, T lymphocyte, and the natural killers. All of these are considered white blood cells here. For the next few slides, we're going to pay attention to more of our red blood cells and platelets. Again, these cells all come from a blood stem cell and they differentiate in size, shape, and the inner contents. As you can tell, the red blood cell here is void of a type of nucleus. It's round, it's ovalish, and it's concave. Here you have the platelet. Doesn't remarkably look much like any one of these cells up here. Again, the red blood cell is for carrying oxygen and nutrients and then bringing carbon dioxide out. Platelets here, main function is to create that platelet plug when there's bleeding that's going on. The myeloblast differentiates into these three different type of granulocytes, and what they're called granulocytes is because of all the granules that are contained within this cell wall. And these are useful in cleaning up the body of different types of foreign pathogens. So they're part of the white blood cells. We look at the lymphoid stem cell, lymphoid, lymphatic system, and the white blood cell. We have the T lymphocyte, which will differentiate and help to create more B lymphocytes. And the B lymphocyte here, and then the natural killer T cell. Here just showing these stem cells once again from this pluripotent stem cell into the myeloid and lymphoid stem cell. Again, these cells are generated within the bone marrow and then differentiated as they grow. If for some reason we are anemic and we require more red blood cells, we would end up having smaller red blood cells called reticulocytes that start to develop in order for us to get more red blood cells. So someone who is low in red blood cells, think about that. Somebody who's anemic. It could even be somebody who's suffering from hypoxia. Hypoxia. So a patient that has an occult GI bleed that is not well noticed or seen can develop more red blood cells slowly over time, or the person that has emphysema and they could have more production or erythropoiesis, the larger increase in red blood cell formation. Platelets. Platelets here we have this platelet large cell here, and then breaking down into the smaller thrombocytes. These are important for clotting of blood. Again, we have the granulocytes, these type of white blood cells. And then we have the larger white blood cells on the lymphoid side. You can see how the monocyte becomes a macrophage. These guys go around and they're basically sort of the trash collectors. They go out there and pick it up and they basically eat it. It's called a macrophage. Macrophages eat up foreign elements, antigens, things that are not are programmed to be removed. Here's the plasma cell. This differentiates into the plasma cell. It helps with fighting infections. This is a picture of a platelet. So what happens when somebody has an endothelial injury or injury to the blood vessel or even the capillary or up on the skin or tissue? We start to bleed, and these platelets start to clump together, and they form a plug in which then we can have the fibrin mesh lay over it and then continue to draw the edges of the endothelial cell, endothelial lining or the vessel lining together to promote the healing. So here we see platelets are really important to clump together to form that platelet plug. Too many platelets can cause the blood to be very thick, and we have more promotion of clotting. That decrease in platelets would cause increased chances of bleeding out. Continue with the clotting system. A lot of those chemicals are created by the liver. These chemicals or signals, cell signaling, causes the blood to clot and create what's called a fibrin mesh here, as we can see down here. And we can see that this cascade comes right down and basically meets here at this one common factor here, factor 10. These factors are given Roman numerals. Helps us to kind of understand the clotting cascade. However, they don't happen in a sequence in 1 through 10. They kind of go in some kind of reverse. Intrinsic, internal, extrinsic, external injury. So this is happening on the inside. Your body has a mechanism within the endothelial lining in the bloodstream. When it finds that there's some type of injury, these factors start to stimulate, and as they go down each step, they form and combine here into the common pathway. So you have an intrinsic and extrinsic pathways, endothelial lining internally, external type of bleeding outside the blood vessel per se, and then here's a common pathway where both of them share for clotting. After clotting, coming down the common pathway, we notice that prothrombin with the factor 10 alpha and factor 5 then turns into thrombin. And with thrombin, fibrinogen into fibrin, and fibrin causes that clot. We also see some other additional factors stabilizing these clots. Here you see what's inactivated by, so these factors all here are activated by heparin. The opposite would be inactivated by warfarin. And then we have some other things like Xarelto that might work on 10 alpha and 10. So you notice that heparin can block all of these clotting cascades. Keep in mind, aspirin does affect the clotting cascade and coagulation, but it works on the platelet aggregation. After the red blood cell is developed, it has about 120 days. Here you see red blood cells are formed because of the nutrients, iron in the small intestines and red bone marrow. And as they live 120 days or somewhere up to 4 months, they then are recycled. You can see that the spleen and kidney are responsible for this. It's showing you that as it's broken down, some proteins are and amino acids are turned into globulin. Some of this heme is then iron is reused and stored and put back into the liver, and the bile is then placed back and packaged in the liver. Some of it is used in digestion, and so we excrete it through the bile and feces during digestion. But a lot of the iron and parts of the globulins that we have, these proteins here, and the iron is reused to create more red blood cells, and then this cycle just continues. If the body requires erythropoiesis or new blood cells to be born and developed, such as in anemia during menstruation, we can increase this production of erythrocytes. Just one more time here, we see how the red blood cell, maybe the slide is a little obscure, but you see that the red blood cells are formed, differentiated from the bloodline, loses its nucleus, the erythroblast, and becomes an erythrocyte. 120 days, it's eaten up, and then its components are broken down. So amino acids go back into the formation within the bone marrow. We have that some of the iron then is restored and put back in. We have the bile and bilirubin then being excreted back to the liver. Here it's processed and then tagged for excretion, which is used in the production of digestion, and then some of it excreted out into the urine. So that's what gives that color change to that darker color change to our feces. Anyhow, what we're paying attention to is the recycling of the products from the red blood cell and how it's reused. More of our bloodline and blood cells and cells in the blood are the white blood cells. Here they're showing you two different types of immunity, humoral and cell-mediated immunity. Humoral immunity is our B cells, and we use antigens. These things are little markers that attach to foreign elements that the B cells then create more plasma cells and memory B cells so that in the future, when we're re-exposed to these foreign elements, these cells immediately come and turn on. On the initial insult to our body, we would have all of these things called the granulocytes. I think you remember if we go back to our first site, these granulocytes, they start to kick up and jump in to help out. They start to eat, and they have macrophages that will continue to eat up and present to the white blood cell here, the T cells, will present these foreign elements by marking them. It's just called antigen and antigen, where they produced an antigen and then it identifies it as foreign. These antigens attach to the foreign element and cause them to clump up, agglutination, and this allows the, the white blood cells to find them and then to destroy them. Further on down, with the cell mediated, there's also where these T cells actively macrophage and kill off these pathogens or foreign cells to the body. So here you see what I'm talking about. There is a process of which this cell it has been attached. It attaches a type of antigen. It then is produced and showing the antigen so that now as this produce and sticks out here, this macrophage can come along. And once this macrophage eats this up, it then can take out these things to uh, identify more of these cells and create more um, B cells, plasma B cells, and more of these antigens. Now these things attach uh, to the foreign elements so that they clump up and that these macrophages can go out there and eat up the foreign elements. Again, here you're seeing a macrophage. A macrophage ingested the foreign elements. It then has these types of antigens. It then produces these that can help for the T cells. So the T cells now I positively identify, they create B cells. These B cells then create more plasma B, and there's more antigens that are produced so that when there are foreign elements, these things attach, these antigens attach to the foreign elements, which allow these plasma and B cells to go ahead and limit the continued growth in the immunity. Okay, once again, going back to our red blood cells. So red blood cells are important in hematology as well as the clotting factors that if we have enough red blood cells, we push enough oxygen and carbon dioxide throughout the body just because they can carry it. Their ability to carry it is based on the hemoglobin. And we look at their red blood cell and hemoglobin and the amount of hemoglobin in the red blood cell called the hematocrit. So a normal red blood cell is about 5. We use the number 5. We use a number 30, excuse me, 5, a quantity of 5 for red blood cells, 15 for the hemoglobin, and 45 for the hematocrit. And we'll talk about this a little later. 5, 15, and 45. So if we're less than 5 on a type of lab slip, when we look at the amount of red blood cells and it's less than 5, we wonder whether or not the person is anemic. If they're producing more red blood cells, they would have more what's called erythroblasts. So these are smaller red blood cells being made. We also look at the concentration and quantity of hemoglobin. So the quantity of hemoglobin within the red blood cell, we're looking at about 15, 1.5. And so if hemoglobin is less than 15, we know that the red blood cell is um, very short of its ability to carry the oxygen. And then we look at the crit level or hematocrit, and that is percentage of that within the red blood cell and blood overall count. So this would be what we're talking about, red blood count. Um, platelet counts, 150 is a good number. Below 150 is thrombocytopenia. We don't have enough. If it's above the 350, 500 level, then we're going to thrombocytosis, where we have too many platelets, and that could cause a lot of clotting. And then when we look for our white blood cell count, the lack of white blood cells would be a type of uh, leukocytosis, meaning that there is less. And when we're looking at the all the blood cells being lowered, then it's pancytopenia. Pancytopenia. Now, one of the reasons why these white blood cells could be overly produced is that somewhere along the line, this stem cell just continues to create cells, and that's when we look at a type of leukemia.